Nurse Executive Fundamentals of the PACU is our episode topic. Rejoining us as guest for this episode is Noreen Hudson, a registered nurse and BRG's team lead for perioperative services. So let's get started.
Welcome to the BRG Nurse Executive Podcast. BRG is a global consulting firm that helps organizations in disputes and investigations, corporate finance, and performance improvement and advisory. BRG's healthcare performance improvement practice offers multidisciplinary services to healthcare organizations. We focus on implementation with innovative, independent, and data-driven solutions. In the BRG Nurse Executive Podcast, we discuss improving patient care by advancing nursing leadership. For more information about BRG, please visit thinkbrg.com. Now here's your host, Nick Chmielewski.
Noreen, thank you so much for joining us again.
Thank you for having me. I appreciate it.
This episode is a continuation of a series we started in season 2, episode 4 back in February, covering the various different departments that comprise a perioperative services division. And in that episode, we covered the operating room, and we also talked about sterile processing department in episode 12 that aired back in June. The remaining components, if I remember correctly, are the preoperative unit, phase 1 recovery, phase 2 recovery, and pre-admission testing. Today, we're going to talk about the PACU, and we're going to group phase 1 and phase 2 recovery into this one episode. So we're really talking about two different things, but we'll cover in this one episode. So what do I need to know about the PACU?
Yeah, so PACU is divided into two areas, like you said, phase 1 recovery and phase 2 recovery. Now, what that is phase 1 recovery is that immediate post-op period where they come straight out of the operating room and go into PACU, which stands for post-anesthesia care unit. A lot of places call it recovery room as well. Same thing, they're interchangeable. And that's really that immediate period where you're trying to stabilize pain, stabilize any sort of blood pressure, hemodynamics, try to stabilize nausea, vomiting, and just give its patients some time to wake up, make sure that their airway is intact, and they're just coming out of that anesthesia in a good spot and not coming out in a very agitated state or a hypersensitivity state with nausea, vomiting, or hemodynamically unstable. It is usually staffed by nurses that have some sort of critical care background. ICU, ER nurses are great nurses to have in your PACU because it is considered an intense recovery department. The staffing in PACU, phase 1 PACU, it can vary. It is very prescripted by the guidelines we go by Aspen guidelines. And it's very prescriptive. And it can be anywhere from a 1-to-1 ratio. It can be 1 nurse to 2 patient ratios. Or if you do a lot of pediatrics, it could be 2 nurses to 1 patient ratio.
Why is that?
Because peds are a little bit more unpredictable coming out of anesthesia. You want to have just a little bit more awareness to them. They're not like adults where we have some compensatory mechanisms that can kick in and help us along the way. Peds are a little bit more brittle and a little bit more unstable and unpredictable. So you want to have a little bit more of a ratio on it. That way, if you have 1 nurse that needs to go get medicines, you still have that other nurse at the bedside watching that pediatric patient, those vital signs and all of that. So it's a little bit higher acuity of care that you want to have those 2 nurses on. It's usually staffed, like I was saying, by nurses with some sort of ICU, ER background. Usually oversight has some involvement with anesthesiologists, checking on the patients, making sure they're okay. And then the final stage of that is to get those patients ready to be either go to phase 2, which we'll talk about here in a minute, or to be admitted to the floor. If patients are admitted to an inpatient unit, they do not go to phase 2 PACU. Only the patients that are getting ready to go home go to phase 2 recovery. Because essentially what phase 2 recovery is getting that patient ready to go home. You're out of that immediate danger period of that 30, 45 minutes post anesthesia. So you're out of that immediate danger period. You're able to breathe on your own. You're awake, you're alert. So now we're going to go to phase 2. And this is where we're going to get you ready to go home, get you up walking around, get you maybe getting some nourishment in you, some hydration in you, making sure you can avoid before leaving. So you'll be in there for about 90 minutes, give or take. And then from there is where we discharge you home. So the important difference is phase one recovery is that immediate period where patients are expected to be in there about 30, 45 minutes and they go to the floor. Phase two, they're going to be there about 90 minutes or so and they're going home. Now, phase two is staffed a little bit differently because those patients are a little bit more stable. You can have one nurse to about four patients in there. Again, you want to make sure that you have the acuity of your patients and know what's going on. 'Cause you might have to go 1 to 3 or 1 to 2, just depending. But for the most part, you can staff it at a 1 to 4 ratio. Now, there is a third phase of recovery to confuse things even more, and it's called phase three that Aspen came out with a few years ago. And really, what phase three recovery is, it's that extended recovery period for two things. One, we're starting to do a lot more outpatient surgeries that require a little bit longer recovery period, such as knee replacements, hip replacements. We can send those home the same day, but we might want to keep them a little longer and get physical therapy to come down, ambulate them, walk them around, give them some instructions. So we might need to watch them a little bit more. If they've had a block of some sort, a neuraxial block, we want to make sure that's wearing off and we're not sending them home with a numb leg or anything. They don't meet the criteria for that immediate phase of recovery, but yet they're not going to be in phase two for about 90 minutes. We're going to have them maybe 4 hours and sometimes even 6 hours. So Aspen came up with what they called phase three to put them into that category. The other thing that phase three recovery also does is we're starting to see a lot of holds in PACU with due to throughput issues in the house, not being able to get them out of PACU and get them into the inpatient units. So PACU's starting to see a lot more holds. So now this is a period where you can discharge them from phase one. They've met acuity, they're hemodynamically stable, airways intact, but we need to hold them. So we're going to put them into phase three holding. And that's, again, it's just an extended period that we're just waiting to get them out of the floor or out of the house.
Okay, so I got some follow-up questions then.
Sure.
You talk about this phase one, phase two recovery and their different nurse to patient ratios. Does that mean that they're different locations and a patient would move from one area to another? Are they done different ways at different institutions? And what's leading practice out there regarding that?
Sure. So it can be done at all of the above. Some of the bigger facilities that we work with, a lot of the AMCs, a lot of big hospitals, it can be physically separated, and it usually is. So you'll have a different staffing pool, different cost centers, different requirements for a nurse experience. So, yes, it will be physically different. In smaller areas, smaller hospitals, it can be all done in the same location by the same nurse because recovery is a level of care. It's not a physical location. So phase one, phase two, phase three is a level of care. It's not a separate department for all of those. So it can be rolled into one or it can be separated.
You mentioned the term PACU holds. How do you measure that? What's the start time? What's the end time? How do you measure that someone is a PACU hold? And if a hospital has got this type of problem, what should they be looking at when they use that term?
When you get discharged from phase one recovery, we call it you met acuity or you return to baseline. Your vital signs are in the ballpark of what they were when you initially came in. Some exceptions to that, but that's just the general concept. You return to your baseline, so you're stable. So that's when phase one recovery time ends. And then that's when we start you in the next level of care recovery. So it's all about meeting that acuity and going into that next level of care. And there should be timestamps that we can separate the two and track that patient. So we can say, okay, this is when phase one recovery was. This is going to be billed to phase one recovery. And then this is when the holding pattern happened, if you will. And it happens, it gets billed differently because you're in that different level of care and that different level of acuity. Does that answer the question and make sense?
Yeah, let me say it back to make sure I understand it correctly. The minute that a patient leaves phase one recovery and is still in your PACU, and is the plan is that they're going to be admitted, not that they're going home, then they are in essence become a PACU hold at that point in time. Is that
Correct.
okay?
Correct. And then when they get to finally go to the floor, then that's when PACU hold ends. And that's how we measure it. So that's how we track the holds. Now, a lot of facilities will sometimes not separate the two. some facilities where if they have a patient that they can't move, they'll leave them in that phase one for that entire time. So you could have a patient that looks like they're in phase one recovery for 2, 3, 4 hours. That's not the best way to do it. It's not the for billing purposes, it's not the best way to do it. From a patient care standpoint, it's not the best way to do it. And you can't track those holds because it's all one big muddy mess. So you really don't know what was actual recovery, what was hold. So those facilities have a harder time when they can't track and trend that whole status to really go back and say, okay, why are we having these holds? What's going on? So you really want to break it up so you can track and trend and then be able to tackle any issues that you have with more precise data to help guide you. The other thing that we like to see is when you do separate out those times, we like to see, okay, what unit are they supposed to be disposed to? Because that's another trend that we look for. So, for example, if 4 North is where the patients are going and you can never get a patient to 4 North, and that's where you have a lot of extended hold hours in PACU, we need to go back to 4 North and say, okay, what are you guys doing? What can we do to help you? Because compared to 2 South, we always can get patients into 2 South, but we're always running into roadblocks for 4 North. So what can we do to partner with you? Maybe bring 2 South in and learn from them what they're doing to make things a little smoother. And maybe we can all partner together to figure out how we can smooth this out a little bit more.
Oh my gosh, I got so many questions. I'm just trying to figure out where I go with this. All right, because we look at boarding in the emergency department as well. And so
Yep.
I guess my question is saying that PACU boarding starts the moment that they turn out of phase one recovery, a fair justification. It's not like you can snap your magic fingers and boof, they go out of phase one recovery and they
Right.
whisk straight to the floor. Or is that the expectation? Because there is some processing time that it's going to take for transport to come and pick up the patient. What should that metric or number be? Is the goal to be
Sure.
zero, or is 20 or 30 minutes a reasonable number?
Yeah, no, I don't think you're ever going to get to a zero target or a zero goal because there's so many variabilities involved with that. So really, it just depends on where do you want to draw that line for the facility. Anywhere from 15 to 30 minutes, it's not going to make or break anything. So do you really want to call that a hold at that point? So it's really working with the facility to see what they feel comfortable with and what their numbers are looking like and defining that. And that's the biggest thing is defining what is the definition of a hold and then setting a target based on that. But I do think 15-minute swing, give or take a few minutes, is a reasonable expectation to not call it a hold. It's just getting that patient prepared. Now, to back up a little bit, there should be no surprises the day of surgery on what patients are going to need beds on the inpatient unit or how many beds are going to be needed or where these patients are going to be disposed to. That should all be pre planned before the day of surgery. So the day before, 2 days before. So if there is any surprises, wow, we have 6 admits. I would argue that we don't have a good huddle process to plan for that in advance of the day of surgery, and that might be worth looking at. But really, there should be no expectation or no surprises on the number of admits that it happens the day of surgery.
Who set the definition for PACU holds?
That's a really good question. So we do have a governing body called ASPEN, American Society of Peri-Anesthesia Nursing, and they set a lot of guidelines, kind of ENA does, AORN. So they set guidelines that help give us some direction as to which way we can go. They don't go so far as saying, drawing the line in the sand and saying, phase one is 30 minutes, phase two is 90 minutes. It's just an industry standard and an industry benchmark. And I always caution people just because we say best practice is 30, 45 minutes in phase one doesn't mean it's right for your facility. It could be less, it could be higher, but it's at least a direction that gives us some indication on where we need to be moving the needle to become a high reliable organization.
If I'm a nurse executive in a hospital right now and I have no experience whatsoever in perioperative nursing, what metrics should I be looking at to better understand, hey, my PACU is running pretty smoothly, or hey, there's some opportunities that I need to focus in on?
Yeah, so I think the biggest one, really the biggest two, would be one, what is your average PACU length of stay? So that's right there is a good indication on how efficient your PACU is. The second thing I would look at is the number of boarders holds and the amount of time that goes with them. And those are two important metrics because one, you do want to know how efficient and how your productivity and labor management is stacking up against your goals for labor management productivity expectations. The other thing is, unless you're a big level one trauma center or a big academic medical center, there's not a lot of PACUs out there that is a 24/7 operation. So they close down typically anywhere from 7 p.m., 9 p.m. So if you have patients that are staying overnight, you are keeping staff well beyond their end of shift, or you're using staff that are being called back on call. So that's going to increase your premium pay. So that can get out of hand very quickly. But more importantly, because we need those nurses back the next day, it can create staffing challenges the next day. If you have a nurse that had to sit on a patient till 2, 3, 4 in the morning, you have to let them go home and get some rest. So chances are they're not going to be able to come back the next day. And now I have a staffing issue. So that's really important to look at that because, and keep in mind that unlike the ED, unlike ICU, it's not a 20 it's typically, and I don't wanna say anything in definitives, but it's typically not a 24/7 operation, so those nurses cannot be there all night.
What are the minimum staffing requirements when you have a surgery after hours? Hey, I'm a PACU
Sure.
nurse. I got called in. I need to recover this patient that had an appy done or this patient that had an emergent whatever done.
You need 2 nurses in phase 1 PACU at all times. Doesn't matter if you have 1 patient in there or you have 2 patients in there. You have got to have 2 nurses in phase 1 recovery at all times. Now, some places will just automatically staff 2 nurses in. Some of the larger places, they'll have a minimum and they'll minimum will always include at least 2 nurses. Sometimes they'll staff 1 overnight and have the second one on call. So when that patient goes into the operating room and they have an idea of when that patient's coming out, they'll now call in that second PACU nurse. Other places, smaller facility, they may rely on that OR nurse to be that second PACU nurse. So the OR does the case and just goes into PACU and stays there until that patient is out of phase 1 recovery. That has some challenges because you might have another OR case that they need to get to. It works, but it does have some challenges to be aware of. And then also, I've seen some smaller facilities. When I say smaller facilities, I'm talking 6, 5, 4 operating rooms, maybe 8 operating rooms. I'll see some of those sometimes call in or call down the house supervisor. And the house supervisor sits in PACU as a backup nurse to fulfill that requirement. The requirement is not for that second nurse to be a PACU nurse per se. It just has to be a second nurse that can do ACLS, BLS, can help with medications, just that sort of things. They don't necessarily have to be a PACU designated nurse per se.
All right. Let's talk about on call a little bit because you mentioned it earlier. Are there leading practices out there around call coverage and how it should be structured? And or maybe to put it more precisely, are there things that organizations should stay away from when they're looking at on call use for a PACU?
Yeah, on call is a bit of a crunchy thing for nurses these days. When you're in an acute or in an in-hospital OR, you're competing against a ASC. ASCs typically don't have call. They typically don't hold patients overnight. So you really want to make sure that you have that nurse satisfaction and a good culture and a good morale because they can go to an ASC and work with a lot better work-life balance. So you really want to make sure that the call is not too burdensome. It's not too much. Your staff isn't getting too burnt out. If you're looking at staff that are taking more than 12, 15 call shifts a month, you might want to reconsider that or look at is that too much of a burnout rate? And I see this quite a bit in, again, I'm going to go back to the smaller facilities where you might not have as much PACU staff available or on staff. So that's a lot higher call responsibility. And you just really need to be careful of that burnout phase and that work life balance phase. So there's no like industry standard, oh, you can't have more than 2 call shift or 12 call shifts a month, or you can't take more than 24 call shifts a month. You just really want to make sure that you're not burning your staff out and it's not too much.
And what are the safety standards or are there safety standards in place regarding I was on call and I was in here all night and doubling back to work a regularly scheduled shift?
So there are recommendations. Again, nobody ever wants to draw a hard line in the sand, but there are some recommendations that they need 6 hours off, 8 hours off, just to get that rest and that fresh mindset to come back. It's not always possible, to be honest with you. There are times that I've had PACU nurses all night and I use them to get the morning done. And then I try to get them out as soon as possible. So really, you have to be aware of what's going on with your staff, where that safety line is for you and your staff as a director, as an OR or a PACU manager. And you just have to be in touch with it and get them out as soon as possible if you do have to hold them over.
Any closing thoughts as we wrap up this episode?
The phases of recovery are phases of care, not physical locations. And they really should be time stamped differently because they all tell a different story that you do want to keep an eye on those metrics because they are what sets the standard for how efficient we are, how smooth we're running, and how we're managing the resources, the staffing.
Noreen, thank you so much for joining me today to discuss all things post-anesthesia care and the PACU recovering room PACU unit.
Thank you, Nick. I appreciate you having me.
You've been listening to the BRG Nurse Executive Podcast, which focuses on improving patient care by advancing nursing leadership. The views and opinions expressed in this podcast are those of the host and podcast guest and do not necessarily reflect the opinions, position, or policy of the guest employer, Berkeley Research Group, or their other respective employees and affiliates.